Okay, I can say definitely good afternoon um, to everyone. Okay, my name is Kizito Gusan. I will be moderating the webinar today. And I'm currently working with FHI 360 on the Act to End NTD program under USAID funding. And I've been working in public health for more than 2 decades, including an NTD. I'm also the focal point for severe adverse event under the Act West program based in Washington, D.C. So I would like to say a special thank to USAID and to Bolivar Poo, our program director, for allowing this to happen. The session is being recorded to be used as training materials. So if you miss few minutes, don't worry. You can catch up with watching it later on. The present webinar has been hosted on Zoom, and I think by now everyone is knowledgeable of Zoom. But for those like me who are still learning, please make sure that you mute yourself when you connected on this webinar. The mute feature is the button, the feature button of microphone in the bottom left hand corner. So the webinar comes about perfect timing, especially during this challenging time with COVID-19 pandemic. Thankfully, the vaccine are available and have reached also, although slowly, low and middle income country. Today, we will talk about adverse event, particularly the severe one, following mass drug administration. The subject matter is an important component of the preventive chemotherapy safety and has a serious effect not only on people who are affected directly, but also on the ability of the Ministry of Health National NTD program. If it's not well dealt with, it will have a direct consequence on NTD program using mass drug administration as main strategy. So the aim today is to review the severe adverse event resources updates, but also to stress on the need for national NTD program to notify and report severe adverse events timely to partners. The agenda that will follow, Yalda, are you still able to? Okay. So after my introductory talk, Dr. Denise Mufassoni will talk about the WHO guidance with that regard. Dr. Yao Soudalon will talk about the safety reporting requirement for Mexican donation. And we have a 5-minute break if we could manage, and go to the case study in Cameroon in Loa Loaco endemic area. And then move to Dr. Kwame Togbe from Togo to introduce us with the best practice through the lesson learned and challenges in reporting. Stephanie at the end will present the new safety reporting requirement for zithromycin donation. And I hope this time we can manage to have a plenary question and answer discussion about and exchange on best practices based on the two cases that Cameroon and Togo will present, of course. So Yalda, if you can manage my slide, that would be great. As introduction, preventive chemotherapy safety is, you all know, is an important component of the safety of the program related to the use of, next slide. So this is a disclaimer about USAID, making sure that the content are the sole responsibility of the program act to end NTD, not USAID opinion. Next. Next. So as definition, as I was saying, for a program that using mass drug administration as main strategy for intervention for NTD program, you need to have multiple successful yearly sustained mass drug administration. So preventive chemotherapy safety are very important. It is indeed given that adverse event, particularly serious, some call it severe adverse event, are expected when you are using medicine for care to individuals, not alone in large scale medicine administration, like the intervention for NTD control or elimination strategy. As indicated early on, the objective of the webinar are first to share the current content, resources, tools, and brochures, including updates. And second of all, to highlight the importance of notification and report timely to partners. Next. According to WHO, the World Health Organization, adverse events are direct side effects of the medicine, and others are caused by medicine effect itself on the organism being targeted, in this case, the helminths. These are commonly referred to as a side effect or adverse drug reaction. Adverse event may also be caused by improper administration of the drug or other factor. Most of the adverse events are mild by nature. At the upper end of the spectrum, serious or severe adverse events are any medical occurrence at any dose that result into hospitalization and prolongation of that hospitalization, or persistent physical disability and incapability, or life-threatening, including cancer, birth defect, and death. Next. So what are we talking about when we refer to preventive chemotherapy safety? The preventive chemotherapy safety covers not only the safe management of the medicine itself, the drug, from the manufacturer to transport, warehousing, and pre-position in the sub-district level for distribution. It encompasses as well the pharmacovigilance, either vertical tied to the NTD program or integrated into the national health system pharmacovigilance. but also the detection, management, and the report of the severe adverse event process are also included. In another hand, the management of SAEs include the prevention and specifically the preparedness, especially for the first round of mass drug administration, because it can derail the whole program. Note that we include here the training of healthcare workers, supervisor of mass drug administration, community drug distributors, and others involved in the mass drug administration. Medical supplies for individuals affected also need to be provisioned in the peripheral health center or district hospital, which do not usually or necessarily have all those supplies to adequately respond to the care of those cases of severe adverse events. So when a severe adverse event occurs, prompt response should be provided. In that sense, in the medical care of the person affected, and of course, the support care that you need to provide to that person suffering with the severe adverse event as a case management. Also, which is very, very important, you have to develop a communication to respond to the community to which that individual suffering of SAEs is part of. It is really, really important. Communicate, have a strategy to tell them that you are dealing properly with, and you have the means to help them address the issue. After properly responding to the individual and the community, it is important to report the SAEs urgently within 24 hours to World Health Organization through the country rep, the pharma, the drug donation programs, and last but not least, the implementing partner, including the non-governmental organization. The how of the process is by notifying by email or other means to WHO using either the SAE forms, WHO. In the case of Act West, we have a tracker that we fill out. And of course, you know the WHO is the medical supervisor in charge of managing severe adverse events and so forth. However, the process continues with investigation within 2 days as per WHO recommendations. The main findings are equally shared with WHO as well as implementing partner accordingly. Next. So the preventive chemotherapy safety evaluation indicator include the timeliness, the completeness, and the accuracy of the severe adverse event occurrence and its investigation that will determine the cause which will lead to corrective action as needed. All these indicators are and action are to be documented in the annual report, whereby you provide the number of course, adverse event and severe adverse event, making sure that you've investigated the causality of those events. And of course, which is a very good best practice, is to the feedback to the health worker, to the CDD, to the community, through the media, and of course, gaining the leaders of the community support. Next. So what are the roles and the responsibility of all the partners? Next. Now, why does this matter to us? Note that in fiscal year FY 2019 and FY 2020, 11 cases of severe adverse events were reported from all the 11 Act West supported countries. following the use of praziquantel, ivermectin, and albendazole in association for MDA supported by Act West program and other partners. For reason I indicated, for any severe adverse event must be taken seriously for the viability of your program. Next. So what are our responsibility now? The National Ministry of Health NTD program must have in place efficient, safely preventive chemotherapy management and evaluation plan and resources in place, which includes the prevention, the preparedness, including the training, the case management, the response to the community, as well as the reporting and investigation of the main finding with partners and especially WHO. Of course, you need to making sure that you've evaluated your strategy or your program to improve performance and address all the challenges that you've encountered throughout, especially with these specific subject matter. I would also like to indicate the responsibility of the partner of the NTD programs, which should ensure that the resources are accessible to the program, like the USAID NTD toolbox and the WHO resources, of course. In addition, all USAID grantees have the contractual obligation to report to USAID NTD program in Washington, DC through FHI 360 within 24 hours of occurrence of the severe adverse event, or when it has been notified to implementing partner or WHO. The grantee of USAID funding with Act West program here include, of course, FHI 360, HKI, and HDI. Next. So what is being asked of us now is to get familiarized with the SAEs following preventive chemotherapy standard resources and tools, including the USAID, as I already mentioned, NTD toolbox and WHO resources. Two is to put in place high-performing safety, including SAE management strategy. And importantly, to notify and report the SAEs to partners immediately, to write to WHO, to pharma, to drug donation programs, implementing partners like FHI 360, HKI, Helen Keller, and HDI. And of course, complete the national SAEs form and complete, of course, the WHO SAE form. Of importance, you should provide also information to the implementing partner like FHI 360 to fill in and send in the Act West SAEs tracker to USAID and any relevant document, including the investigation main finding and the SAEs annual report for action. Next. So all the information are recorded in Act West Serious Adverse Event Tracker, which is an Excel form, as that's what the Act West program use for reporting format. So the tracker in this case has no identifiable information for the patient, but has three parts, with the initial information collected like history, date of possible SAEs, because it is the initial potential SAEs, the age, the sex, and so forth. The second portion collects information with regard to the investigation finding, like the description of the event, the date of the investigation by the appropriate department or division of Ministry of Health, or by whoever is in charge within the NTD program. And of course, the conclusion of the program. And the third part, you can guess, is about the next step, including only the resolution and the immediate action that you need to take and the long-term recommendation. Next. So the resources that I like to share with you next are these: the USAID handbook for managing adverse events following mass drug administration and serious adverse event, the USAID job aids for managing adverse event following mass drug administration and serious event, and the WHO guideline about the safety of preventive chemotherapy intervention for the control of NTD. Of course, the program manager training courses, the WHO one, specifically the module 5, session 3 and 4, with regard to preventive chemotherapy safety and the management of severe adverse event and surveillance. Now, the last one is about the update annex safety reporting requirement on zithromas donation MOU for drug donation for zithromas donation program. Next. So the panelists will present after me on the WHO guidance on managing reporting SAEs, the reporting requirement for medicine, the Cameroon case study with regard to Loa Loaco endemic area, and the Togo case management that we like Togo best practice to be shared with the challenges, and of course the new requirement on zithromas. Thank you. On that note, I will quickly introduce Denise. Denise, are you ready?
You're on mute, Denise.
Sorry. Yes, I'm already.
Okay. Okay, Denise is a medical doctor with a master in epidemiology and biostatistics, and she works at the World Health Organization headquarters in the Department of Neglected Tropical Disease. As a technical officer, her work focuses on community and primary care intervention, which includes school-based deworming and mass drug administration. Before joining WHO, Denise worked in Rwanda as the first national coordinator of the NTD control program, and then joined the US Center for Disease Control for 4 years. Denise, take it away.
Yeah, thank you, Kizito. Good afternoon, good morning. As Kizito said, I'm going to present you what WHO is doing currently on NTD drug safety. So we have already a document, a manual that was developed in 2011. So what we have done is to update this manual to be able to fit some important information, but the recommendation are the same as the one that was in the last documents. So this manual is what we are working on. Why we decide to have a new manual is that this is not what there is a responsibility. We have two responsibility as a public health program. We have to deliver health benefits to the community, but all as well as to minimize harm. So that's where safety come in. And we want also to increase the NTD program visibility and to respond to the World Health Assembly that request to the Secretariat to promote a safety culture and to provide technical support and material guidance on drug safety, and also to develop programs for patient safety education and training. So what was missing in the existing documents? We have many documents on drug safety, on NTD drug safety, but we want to put it in to have a consolidated manual on that, and also having a document to create awareness and improve the skills as a training manuals and job aids. And the last one is to get reliable data on serious adverse events and their prevention. So for this manual, the objective is to provide practical tools that will support the programs on the planning, preparation, and monitoring of safe administration of NTD drug. There will be a manual and training modules and job aids for program managers and drug distributors. So the audience is the program managers, the national and subnational public health workers, community drug distributors, WHO country office and regional office, NGOs and donors. So what are the content of the manual? We have about the introduction, the module 1, we have the safe drug management, and we have the choking prevention, pharmacovigilance, and also how to manage the serious adverse events and how to report them. And the last one is on communication and remote control. So we think that this module is the one that will help to improve on the safety of the NTD drugs. So I will not, I will skip the introduction. The second module is on the safe drug management. So we know that that's where it starts, the safety. It starts on the manufacturer. It starts on also on the to ensure the quality of the drug that's country are purchasing, or the donated drug to country. Also on the formulation of the drug, if it's age appropriate formulation, and also on the shipping and storage, safe drug administration, which include the exclusion criteria and proper dosing and safe drug co-administration using the recommended co-administration drugs. So this module was not in the previous documents, but we found that we got many cases of death due to choking, and this is something that can be prevented. So we thought that it's very important to talk about choking prevention. So and what I say, it's tragic and preventable. So the first preventive measures is to use the WHO recommended age-appropriate drug formulation for young children where it's available, or to crunch the tablets where the formulation are not available. But the most important preventive measures that we insist in this document is not to force young children to take medicine if they don't want. So we need to talk to them, we need not to force them. So it's something that should be emphasized during the training of community drug distributors, and also to prepare them to discuss this with the parents of their children. Another module that's was not well discussed in the previous document is the collaboration between the Pharmacovigilance Agency and the NTD program. We know that these both programs have similarity in their objective. So we know that pharmacovigilance objective is to detect, assess, and understanding and prevent the adverse events. So and it's the same for the NTD program as far as the prevention of serious adverse events is concerned. So these two programs share goals and they is to improve people's health and well-being and contribute to a safe, flourishing society. And also they share responsibility to improve the NTD drug safety awareness and in preventing the intent harm. And also they complement each other. So this module show how these two programs can collaborate and how this can have advantage for both programs in this collaboration to achieve their goal. Fifth module is on how to recognize, manage, and report the serious adverse events. For preventive chemotherapy, where we use drug distributors, it's mostly that's where we insist on preventive chemotherapy, but also we talk about for individual treatment, for the NTD case management. Although these are treated in medical facilities with medical personnel, trained medical personnel who knows how to take care of serious adverse events. So it's why we don't go through details on individual treatments, but we just talk about the adverse events that can happen for all the NTDs that on the 20 NTDs. We put it in a table. So, and also we insist on how to respond to serious adverse events, how to investigate them, and how to report them. And also insisting on the planning and preparation, because to be able to respond well to the serious adverse events, the people need to be to have planned that and to have prepared for that. The last module in the document is on communication and remote control, which is very essential for the safe NTD program, and it's required at people level, at individual level, community level, but also for the media. So the media needs to know what you are preparing, what's the serious adverse event or adverse event that can happen. So then that's why we say it's required before the MDA and during and after the MDA. So it's very important, especially when these serious adverse events occur. So that's why people need to be trained on effective communication, and because you have to learn that and it requires practice. Another thing that we insist in the document is that the NTD program should have a communication plan that they can trigger when these serious adverse events occur. So if you don't have it, then you will miss the communication, and this can jeopardize your mass drug administration events. So that's all the modules that will be in this. Where we are now, we have the drafts that have been edited, And we have also the training module and the job aid for program managers and for community drug distributors. So once this is finished and the layout is finished, we'll be able to distribute through the regional office and country office, WHO country office. But also the training module, we want to put it will be online. Now NTD has an NTD channel on the WHO website where you can find the training module for many MTDs. So we hope that once it's finished, we will put it and it will be available for everyone to use. Thank you.
Thank you, Denise. Yeah, I think we're next. We're making sure that we finish the talk and then go to the Q&A session. Dr. Yao Sodalon is Dr. Yao Sodalon is the director of a Mexican donation program. He is responsible for the overall success of the program, ensuring Mexican reaches everyone who needs it. He works closely with partners to shape strategy for the elimination of onchocerciasis, commonly known as river blindness, and the lymphatic filariasis, commonly called elephantiasis, lymphatic filariasis, LF. Dr. Sodalon joined the program in 2006 to manage the donation of mectizan and albendazole for LF elimination in Africa countries and Yemen, where onchocerciasis is co-endemic. He was also responsible for monitoring the distribution of the drug to ensure it was safely administered during mass drug administration. Before joining MDP, Dr. Sodalon worked in the Ministry of Health in Togo, his home country, as director of the Division of Clinical Laboratories, Health Strengthening Policy and Development, and contributed to the various communicable disease control programs, including malaria, tuberculosis, schistosomiasis, and lymphatic filariasis. He also taught clinical parasitology at the Lomé School of Medicine in Togo and consulted for WHO support in African countries in malaria drug monitoring and policy maker. Professor Sodalon, please take it away.
Interesting. Okay, thank you. Thank you, Kisito, for this very nice introduction. And hello, everyone. I'm tasked to share with you the SCE reporting system that we put in place like 30 plus years ago when Merck decided to donate mectizan for the control of river blindness. Oops. Okay, how mectizan is used and when? Mectizan actually is donated for mass drug administration alone for the treatment of onchocerciasis, or in association with albendazole for the elimination of LF in countries where there is onco. And now recently, in association with albendazole and DEC, known as IDA or triple drug administration for the elimination of LF in countries where there is no onco. Mass drug administration in some communities are initiated with prevalence as low as 1%, which means that in 100 people, 99 people of them will be treated without being infected. So safety must be very, 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 very key. They are not sick, don't hurt them. Why we need to monitor safety? This is critical for the success of your mass drug administration program, because if it's not safe, people will not comply, it will kill your program. It's also required by the regulation authority to improve the product's post-marketing safety. Regulatory system that we are using actually is American FDA. How medicine safety system is organized. As I said, is in place since the inception of the program 33 years ago. The applicant countries are sensitized during the application review process to be able to monitor any adverse events that will occur during the mass drug administration in order to promptly detect and manage all cases that are severe. And following that, to report the cases to MDP or to any other pharmacovigilance system as required in the country. Bear in mind that when this program started in 90s, there was no pharmacovigilance system in the countries, which actually is recent, starting beginning 2000 when the Global Fund program were launched. Case definition will be considered as severe a case that meets one of the following criteria: death, life threatening, hospitalization, persistent or significant disability or incapacity, congenital anomaly, or birth defect, cancer, overdose. It's a very standard definition of severe adverse event. It has nothing specific to medicine or any other entity medicines. When a case meets one of the criteria, it has to be considered as severe and reported to MDP. So in practice, the program management is required and has the demonstrated ability to monitor any adverse events and detect quickly, early the case and manage them appropriately, in general, free of charge for the patient. And then, as I said, report the case promptly to MDP using this form. The form is then the case is then reported by MDP within 2 working days to Global Safety team, and there is a retro information system. We interact with country, including follow-up of the cases and or clarification, case symptom or whatever clarification. And most important, we discuss the cases during our MEC meeting and or during scientific working groups. This helps us to learn lesson and put lesson learned into good practices. I mean, to guide, to improve the safety of the medicine. Those who are aware of what we call a TCC MEC guideline for use of medicine in countries where there is lower. That's as a result of those meetings. In settings where medicine is used for LF elimination, the process is the same. The difference are twofold. The first one is the form. The form is different because it contains a room for albendazole and medicine, and also the case is reported to the pharmaceutical company that donates albendazole, which is GSK. Actually, starting 2012, the American FDA and European EMA required that all adverse events following preventive chemotherapy to be reported by the countries. As a result, the pharmas that are donating medicines to for NTD control and elimination got together to design a new form, which actually is here. The form is a standard form that has a room for all the medicines that are distributed through mass drug administration: albendazole, azithromycin, PEC, ivermectin, mebendazole, praziquantel, and whatever, whichever medicine is distributed during the preventive chemotherapy. The way the reporting is done also is written on the form. I actually sent mainly to medicine that is involved in the mass distribution. It's not readable, but bear with me. It's available in our Medicine Adoration Program website. From that theory to the practice, the system has worked, because we, following the MDA with ONCO, we received so far 1,056 cases. The cases were reported as far as 90s, and you can see the graph. It went up in 2006 when the program expansion started in DR Congo, and we see a nice decrease following that, to be now, starting 2015, very sporadic, between 0 to 3 per year. Of course, probably those are under-reporting cases, because the culture of reporting is not in all the countries. As a result, we can see here that only two countries, DR Congo and Cameroon, are the main reporters, and we can see that 97% plus cases were reported from those two countries. The cases are associated with the endemicity of Loa, which actually makes CDTI very complicated to implement in those two countries, but things are going well. How the cases what is the diagnosis of those cases? The most important feature is neurology, and we can see that 43% of the cases are neurologic, and most of those also are accompanied by coma with a high fatality rate. So neurologic cases, and those are mainly reported from settings where there is Loa. We, following the treatment with the association albendazole and metizone, we have fewer cases, 62 so far since 2002. The maxi that we received were from Cameroon, in 2013 from Cameroon, when they scale up their LF program from CDTI or ONCO to LF program. Where those cases are reported from, again, Cameroon is the most reporting country, followed by Ghana, and we received one case from Timor-Leste two years ago, following the triple drug administration. The clinical features here, the most concerning is the severe cutaneous adverse reactions, which we actually had from Cameroon, Ghana, Burkina mainly. And the feature, you can see very, very severe case like this, Lyell syndrome, which was reported from Burkina in 2013. So this is something you guys need to be careful about, because it can happen anytime. It's linked to sensitization, so it can happen anytime. And other drugs are used also that can lead to this kind of cutaneous syndromes. So those are what I want to share with you. Of course, safety need to be very seriously taken into account in your program, because you are treating people that are not sick, and you need to maintain trust in your program, or you kill the program if you take safety lightly. That's over to you, Kisito. Thank you.
Thank you very much, Yao. So we'll take a 5 minutes of break and come back. Unfortunately, the 5 minutes will be 4 minutes. So we come back at 55 of the top of the hour. So that's mostly 4 to 3 minutes. So you can take a bio break or, relax a little bit. Okay. Professor Camille, if you have, I believe I've seen you on the Joseph Camille. Yalda, do you see Joseph on the, I can't see him on the list, so maybe I'm not looking properly.
Actually, I also did not see him on the list.
Okay. Dr. Kwame, Dr. Togbe, if you don't mind, you will go next.
Yes, I'm here. Yes, I'm here. I think I misunderstood that I was supposed to be in this, to be presented in this session. So I'm taking a few minutes to translate my French presentation quickly. So hopefully Joseph will be here, but if he's not here, I can take over.
Okay, I'm still looking at we can change things around. If Stephanie is on. I can see Stephanie. I see Stephen, but not Stephanie.
I'm here.
Oh, you here? You there? Oh,
yeah,
oh,
I'm here.
yeah. Sorry about that. Okay. Do you mind going before Dr. Togby?
Not at all. So there's one more presentation, and then I'll go, and then Dr. Tokbe will go.
No, you go. You will be the one next.
Oh, I'll be the next one. That's fine. Yeah.
Yes. Okay. In about 1 minute.
Okay, that's fine.
55 minutes on the top of the hour.
Okay, that sounds good. Yeah, I can do that.
Okay, thank you. Okay, sorry about that. I was just talking to Joseph. I hope he can connect and then we continue. So you all know Stephanie Palmer. She's worked for over a decade on NTDs, in the field of neglected tropical diseases, with a specific emphasis on trachoma. She began her public health career in NTD as Peace Corps volunteer in Togo, fighting guinea worm, and as guinea worm technical advisor for the Carter Center in Niger. She currently serves as the trachoma technical advisor for USAID Act to End NTD West program, which supports 11 countries in West Africa to control and eliminate 7 of the neglected tropical diseases. Prior joining FHI 360, she was working with RTI and Helen Keller, and was the program development coordinator and assistant director, the trachoma control program at the Carter Center. Stephanie, if you're ready, please take it away.
Great, thanks, Casito. Just a second, let me share my screen. It's a pleasure to be here with all of you, and thank you so much for participating in this webinar. Because ITI wasn't able to join us today, I was asked to give a very brief presentation on some changes in Zithromax dosing and reporting. Most of this won't be new to you. And if you have got any difficult questions, I may need to refer you to ITI, but I'll just give it a very quick overview. So as you know, a couple of years ago, there was a change in the dosing with the powder for oral suspension, or the POS, that's given for children of Zithromax. And primarily this was due to some choking deaths that had happened when giving young children pills. So previously, the POS was given to any child under 5 years of age and over 6 months of age. But due to those choking deaths, they raised the age for children who should be receiving the POS. So now it's children who are 6 months and above and under 7 years, or it can be height-based if the child is less than 138 centimeters. And just a few guidelines we want to kind of highlight. First, you know, our overarching goal is zero serious adverse events due to choking and better management of treatment to children. And what we want to also highlight, you know, these are all things that are in the Zithromax Program Manager's Guide that ITI has put out, but certainly principles that we also want to make sure that we're supporting under Act West. So no child should ever be forced to take Zithromax, or any person for that matter. And, you know, if there's a child who's uncooperative or anxious, try to calm the child before trying to give the Zithromax to them, or any other drug. Never hold the child's nose closed, or shake the child, or force his or her head backwards to make them swallow. And if the child is still being resistant, it's okay to mark the child as refusing treatment. We'd much prefer to have them marked as refused treatment than to have a serious adverse event or other adverse event happen to them. And then finally, even though the guidelines call for children over 7 to start taking tablets, the POS can be provided if they've got trouble swallowing, because again, we want to make sure that the children aren't choking on the pills. And there were just very recently a couple of minor changes to the reporting requirements for Zithromax. And because we want to make sure that we're supporting what is being required by the donation companies, just want to highlight these here. So this is the former requirements that are written in the MOUs that Ministries of Health sign with Pfizer, or sorry, with the ITI regarding reporting to Pfizer. And so the expectation was that all adverse events, at-risk scenarios, and product quality complaints would be reported within 24 hours of awareness. And then there's been a slight change to now where any adverse events, at-risk scenarios, product quality complaints, and unexpected therapeutic events are reported either within 1 business day or 3 calendar days, whichever is shorter. Trying to, note that these might happen on a weekend, and reporting within 24 hours may not be feasible on that side. So we just want to also then highlight that, as Casito had mentioned when he first spoke, that reporting, of course, is, as ministries already know, they've signed MOUs required with the pharmaceutical companies, but we're also required to report these to USAID. So, please do report these to us as well, so that we can make sure that USAID is also aware. And that's all I had to present, but happy to take questions at the end of the webinar today, if there are any.
Thank you. So I have Joseph here joining us. Joseph, if we don't mind, I know that you were born ready, so if you can unmute yourself and let me know if you can go ahead. Okay, great.
Yes. Can you get me? Can you hear me?
Yes, Joseph, we can hear you.
Okay. So,
Joseph, I can hear you. So sorry, I muted myself and I was talking to myself.
Okay. Yes.
So yeah, great. Thank you. Let me introduce you quickly. Professor Joseph Camio is a medical doctor from the University of Yaoundé 1 with a diploma of epidemiology, a master of public health, and a PhD in epidemiology from the University of Paris 6. He's currently teaching epidemiology, surprise, surprise, at the Faculty of Medicine or Biomedical Science at the University of Yaoundé and head of the Department of Public Health. He's also founder director of the Center for Research on Filariasis and other tropical diseases. He's member of the Cameroon Academy of Science, awarded in 2015 the Islamic Development Bank Prize for Science and Technology in recognition of his contribution at the socio-economical development of his country in Cameroon. His main research are neglected tropical diseases, mapping clinical trial, pharmacovigilance diagnostics, tools, and post-MDA impact evaluation. Of course, he has authored more than 120 publications in scientific journals. Joseph, please take the floor.
Thank you. So I have to present the community-directed treatment with ivermectin in lower cisco-endemic areas, particularly the SAE surveillance, management, and prevention. Concerning the context, it's not moving. I don't know why. Sorry.
Maybe go on presentation mode. Great. Presentation. Okay. There you go.
Okay. Concerning the context, ivermectin is a large spectrum antiparasitic drug. In Cameroon, with the treatment in forest areas, cases of severe adverse event SAEs were recorded. The first case was described in 1991 in the Littoral region in Cameroon. After this case, Hospital-based and field studies were conducted to determine incidence and the risk factors of post-ivermectin SAEs. This was very new because during the development of ivermectin, no severe adverse event was described. So it's when we started treatment in forest areas that we observed these severe adverse events. After the hospital and field-based studies, the main risk factor was high low-assist microfilarial load. The patients with more than 30,000 mF/ml are those who developed these SAEs. And as the microfilariemia was high, the risk of these severe adverse event was also very high. So patients with 200 mF or 300 mF/ml had a very high risk of SAEs. The incidence was 1 to 2 cases per 10,000 treatment during the first years of treatment. And after these studies, as the proof of the SAEs was established, Mechanism Expert Committee and African Program for Onchocerciasis Control, APOC, agreed to institute a position in onchocerciasis and low-assist co-endemic countries. This position was concretized in Cameroon in 2003, and Dr. Bjorn Tilfors, former director of MDP, formalized this process. The main duties for this position supported by MDP was the surveillance of post-ivermectin SAEs, the report of these SAEs to MDP, the Ministry of Health and EPOC, training of health personnel for the diagnosis and management of these post-treatment SAEs. This post has also the responsibility of conducting research for better understanding of the pathophysiology of these SAEs, the other risk factors, and also better management of these SAEs, because there were some death with these post-treatment SAEs. Also, there was a need to regular report of the main results of research to the Mechanism Expert Committee and also to the Ministry of Health. And the results of this publication was to report.
Sorry, the slide is not moving.
Ah, the slide is not moving.
Yeah, unless you.
It's moving here. I don't know.
Okay.
Is it moving? No. No,
it's still not moving.
Go to presentation mode.
Yeah. Presentation mode.
Let me go to.
On the.
My God. Let me see.
Presentation mode is on your bottom right.
Mr. Joseph, if you want, I can run the slides for you.
Okay, maybe let me.
On the bottom, under 9, you have on the bottom your comment tableau. Tu cliques sur le tableau.
En fait, l'écran de Zoom s'est réduit. Alors, j'essaye de.
Joseph, you want Yalda to take over and run it for you?
Yes, maybe.
Okay, Yalda, please.
Sure. Please stop sharing your screen so I'm able to share my screen.
Just go on, and then you will cancel my own screen.
Actually, please stop sharing because I will not be able to share my screen.
Joseph, he cannot, she cannot do that. You need to stop sharing.
Yeah, because you are co-host, so.
Okay, let me see. I'll start the process, and maybe I'll just I'll close and then.
Yes, there you go.
Okay.
You are which slide 9?
And slide 9, yes.
Okay. Thanks, Jan.
Let's go behind because I was not yet up to this slide, please. Again, back again. Yes, this is where we were, where I was. So the duties of this post was to conduct research, better understanding, and the publication of results. Next slide, if it is you. These positions were instituted in Cameroon, in DRC, and in Angola. And Cameroon team went regularly to DRC and Angola to train those in these countries. Next slide. With the discussion during that period, there was a strategy for community-directed treatment reivermectin in the context of LOASIS. And the process used to start with the mapping of LOASIS with the RAP-LOA method, rapid assessment of LOA. And there was also the refinement of onchocerciasis in these areas to make sure that onco was at least mesoendemic in lower endemic areas, because at that time there was no treatment for hypoendemic areas, and it was not reasonable to take the risk of severe adverse event in hypoendemic areas where the benefit of onco treatment was not so high. So the refinement allowed to exclude hypoendemic areas and to treat only meso and hypoendemic areas. Not yet, please. After the mapping, there was a training of health personnel for the diagnosis and management of post-reivermectin SAEs in these areas, and also the procurement of drugs and consumables for the management of post-treatment SAEs in reference hospital. Next slide. And this is the secret of the surveillance of these SAEs. During the training of CDDs, there was well explained that there could be post-treatment SAEs. So in the communities, they also informed the population that there was a possibility of these post-treatment SAEs. And when there was a case of SAEs, then the CDDs were informed. And when the CDDs informed, the nurse, head of the health center, was also informed. And when the nurse confirmed, he informed the physician, the head of the district, about the case for the management. Also, the intermediate and the central levels were also informed to make sure that everybody was aware that there is a case of SAEs. And as we were in charge of these SAEs, we used some time to travel to a peripheral level to confirm these SAEs with calibrated blood smear and other tests to confirm the case of SAE. And these last years, as I was explained, when the national program is aware that there is a case of SAEs, the pharmacovigilance service at the direction of pharmacy and drugs at the Ministry of Health is also informed so that everybody is aware that there is a case of SAE. And all the forms of SAEs, as Yao presented, we report them to Mechanism Donation Program. Next slide. This is the geographic distribution of these SAEs in Cameroon, and they were only in low-assist endemic areas, as we saw that low-assist was the main risk of this severe adverse event. Next slide. And this is the incidence from the first year to the 10th year. At the beginning, the incidence were high, and progressively with years of treatment, as people with LOA were treated and the high MF lows were rare in the population, the incidence of these post-treatment SAEs were also very low. Next slide. In conclusion, what we can say is that ivermectin is highly safe. Roughly, the incidence of SAEs during the first years were around 2 per 10,000 treatment. And after 10 years of continuous treatment, the incidence decreased to less than a case per million treatments. Nevertheless, the surveillance is still needed as cases of death have been recorded due to the fact that the training that were organized before treatment campaign were irregular in lower endemic areas. And we have discussed with the Ministry of Health in Cameroon to institute the training at the intermediate level, at the regional level, where health personnel are more stable, because at the district level, personnel are unstable. And when you train them, after 1 or 2 years, they are transferred and you have to come back to train again. But at the regional level, they are more stable. If we train at that level, they can manage the post-treatment SAEs. Next slide, please. The position that was instituted in these countries, in Cameroon, DRC, and Angola, improved the surveillance and the management of post-treatment SAEs, and globally the CTI in these countries. Many results of the research related to these SAEs has allowed the prevention today with the new strategy, the test and treat strategy. And we have used this strategy to treat more than 100,000 people in lower endemic area in Cameroon without a single post-treatment SAE. Next slide. Thank you for your attention. Sorry for a long presentation.
And that was very insightful. I like that. Thank you very much, Professor Kamyu. Dr. Togbe, are you ready to take the floor?
Yes, I am.
Okay. If you are, do you mind me introducing you quickly?
Sure, that is fine. Thank you.
Okay. If I can. Okay. Dr. Kwame Togbe is a medical doctor and a public health professional with a diversified experience beyond healthcare and primary care. He got offered and accepted to serve in Togo NTD program as the coordinator in May 2019, and when he was officially appointed. Prior to joining the Ministry of Health, he served as a volunteer as the U.S. Peace Corps. Dr. Togbe earned his MBA and PhD degree from the University of Nebraska, and he is perfectly bilingual. So no surprise that he's here, and he can speak some Portuguese and Spanish. Oh man, he's complete. Dr. Kwame, if you're ready.
Okay, thank you, Kizito. Let me share my screen quickly. Okay, can you all see my screen?
Yes.
Okay, I'm pleased to share with you Togo's experience regarding the monitoring, detection and management of severe advanced events during MDAs. For this presentation, we will follow this outline, starting with an introduction. We will cover the entities. We will see the entities covered in Togo and the implementation process for those MDAs. We will also talk about the epidemiology of SAEs and the monitoring and management of those events. And also I will share with you the information flow about those events, the investigation, some lesson learned, and the challenges. Togo is a small country located between Burkina Faso, Benin, Ghana, and the Atlantic Ocean, with 7.7 million people. The health system is divided into six health regions with 44 health districts. Each of those health regions or those health districts has one focal point. So the NTD program has its own focal point at each level. The pharmacovigilance department has its own focal point at each of those levels too. The country has about 1,271 health centers, and 687 of those are from the private sectors. And for the MDAs, we work with almost 12,000 community health workers. The NTT program in Togo covers 11 diseases, and for the MDAs, we take care of 3 of them: onchocerciasis, SGA, and schisto. Togo has already eliminated LF in 2017, as well as 2 other NTDs. We started conducting an integrated MDA since 2010. So each year we carry out 2 rounds of MDAs. The first one occurs in May or June, and the other one happens in December. During those MDAs, the community health workers are the one that stop by any house, any household to give those drugs, and the MDA is conducted in the whole country except in the Grand Lomé region. So during the MDA, we give ivermectin for onchocerciasis to 5 years old and above. We give albendazole for STH to school-age children, and we also give praziquantel to school-age children and sometimes to adults. I think I can just skip the definition of severe adverse event, since people before me share those definitions with you. In Togo, during the last 3 years, we have reported some severe adverse events. During the 2018 MDA, one death case was reported out of 196 adverse events reported in total. In 2019, we reported 7 severe adverse events, and out of those, 1 death was reported. In 2020, due to the pandemic, we were not able to have both rounds of MDAs on time. So the first round was conducted in September, and the second one was conducted in February of this year. That is the reason why I can only share data regarding the first round with you. So this year, for 2020, we did not report any severe adverse events. On this slide, I can use to collect data about those SAEs. It is in French. Sorry, I was not able to provide a translation for this. And before every MDA, or at least before the first round of the yearly MDA, we train all actors, including community health workers. So during those training, we explain them how, what is the process to monitor and report those events. So those community health workers are aware that before giving any of those drugs, they should explain to people how possible severe adverse events will be managed should it happen. No matter the severity of the side effects, the community health worker has to send the patient to the health center, to the nearest health center. The health center manager should treat the case if possible and report it to the hierarchy, which is the district level focal point, and that focal point has to report it in return to the regional focal points. Any severe adverse event should be reported immediately to the NTD program by the regional focal point. Normally, all those severe adverse events are treated free of charge at the closest health center. So it has to be, the patient is sent straight to the hospital before the causality is even established. We have two information flows when it comes to the reporting. The pharmacovigilance has its own reporting system, which starts from the health center, goes to the district level, the regional level before reaching them. So they do this routinely every month. On occasion, only when we are conducting our NDAs or the NTD program, use its own reporting system. It's very similar to the one used by the pharmacovigilance department. So the information.
Can you wrap up?
Oh, okay, sure. The information flows from the health center to the NTD program. The case is then investigated by the pharmacovigilance department, who conduct the investigation with the help of some doctors and some other person. And we learned that setting up the monitoring system is very helpful to manage the cases because it is an opportunity for us to collect data that help us to establish the causality. Some of the challenges I can share with you that we need to improve the collaboration between the pharmacovigilance department and the NTD program to boost the reporting of those events. And also we need to effectively provide a free of charge care to those patients. And we need to advocate to involve our partners to cover at least parts of the expenses related to the care of those patients. This will be my last slide, and thank you for your attention.
Thank you very much, Dr. Togwe. I'm not sure that we have much time. We have 1 minute. If you bear with me, you can use the raise the hand from the reactions feature if you want to ask a question. And I hope we get a couple of questions because there is no question in the chat. No question in the chat. So if someone want to comment and ask a question, that would be great. No hands up. Should I just adjudicate? Okay, Diana, you wanna ask a question?
No, sorry, somehow my video unmuted. Sorry, I didn't mean to do that.
Okay,
I don't know
that's
what
fine.
happened with my computer. Thanks though. Thanks for the
That's fine, thank you. If you
Is it
bear
off?
with, yes?
Yeah, I would like to ask a question. First of all, thank you all for the great presentation. It was very informative. I think sometimes in the countries, something that may be missing is to involve the media. The media and they play a big role in terms of information, spreading rumors or combating the rumors. And it's important for them to sometimes be aware of the NTD program, the MDA, and the potential severe adverse event. I think some countries have went forward to even have to train journalists for them to be able to understand what is happening and to be part of this NTD world that may understand better the problem of severe adverse event. I don't know, maybe in terms of policy or actions, not only for countries, but also implementing partner and WHO, there is a way to integrate it during, planning and make sure the communication people are also involved in terms of preventing, rumors, or at least making sure they get the right information to the people. So the question is more open to maybe MDP, WHO, or Dr. Togbe.
Sorry, Achille, was that question addressed to me?
Yes.
Yeah, can you repeat the question, please? Sorry, I was not.
What do you do with the media in Togo? Do you involve them? Mass media.
Okay. To prevent rumors before the MDAs, what we do is we use local medias to share the information about the upcoming MDAs with the communities, and also during the social mobilization, we use the we use the community health workers and the public healers to spread the information about the upcoming MDA. They explain to the communities that those medicines are there, are distributed to help them prevent those diseases, not to cause anything harmful. But we also make sure to explain them that some side effects are possible, and should they happen, they should receive free care at the nearest health center.
Okay, thank you, Dr. Togbe.
Yeah,
Denise, please.
Okay.
Yeah, I think that's the way to go. He explained. Just we need to involve media at the beginning of the preparation of the NDA by training them, by letting them know that this is the drug that we use, this is the potential side effect that can happen. So when you are involved with them, when they know, even when it's happened, they will not report from us because they know. So I think it's important to train them.
Okay, thank you. Yeah, back to you. Over to you, Kizito.
Thank you, Ashi. So I'm not seeing another hand. You can just unmute yourself. So I can allow one if everyone bear with me. We're 5 minutes over the time. I'm sorry about that. But let's allow for one question or comment.
I'll go with the comment just to say that concerning the media, yes, we have to, we could inform the media, but we should, this should be done by really experienced people, because this can also disturb significantly the program. Because I remember we had some SAEs in the South region and the medical doctor informed the press, and that was not really good for the program because the way he informed the media was not good at all. So I think if we need to do that, we have to really organize and know exactly who should inform the media and how he should inform them, because that can really disturb the program also. Thank you.
That is indeed very important. Thank you, Joseph, for emphasizing on that communication strategy in place and known from all the actors. So on that note, I would like to thank the presenter, Dr. Kwame Togbe, Dr. Yao Sodalon, Dr. Denise Mufasoni, Professor Joseph Kanyo, and Stephanie Palmer for their time and drive to put together in record time the material and the slides. I owe you a debt of gratitude for all the new insight into this essential element of preventive chemotherapy safety. I'd like to acknowledge the incredible support from Yalda Rizai, who had tirelessly worked with me to put this webinar together. Thank you, Yalda. And all the AtWest team who have helped me as well organizing the webinar. As we close out this webinar, I hope you all will move forward in your work with renewed energy and commitment to improve and strengthen your program through safety delivery of mass drug administration. I encourage you to visit AtWest's website to listen again to the recording if you've missed a few minutes. It will be posted as soon as possible, or Yalda will send you a link to listen to it, or Cathy Sanchez. If you need additional information, feel free to contact us or myself personally. Lastly, but not least, thank you each one of you for taking time out of your busy schedule to participate in this webinar with your very insightful comments and questions. Be safe and have a great remainder of your day. Until we meet again, à bientôt.